saved millions. We have lost millions of lives in war, and we don't want to see more loss because of man-made policy. I want to see my children grow up, getting married, having family, living happily and safe. So as citizens, as patients, as doctors, we demand change, and you are the one who can help to make change happen. We demand that health people and society must be at the center of drug policy. That policy that punishes drug users must come to an end. And we demand that adequate investment must be made in harm reduction programs. We know it works, and it works for everybody. Thank you very much.
Thank you very much. It was a very inspiring talk. Just got time for one quick question, pertinent specifically to the presentation you just heard.
I think we all agree. Thank you.
Okay, without further ado, I'm going to introduce Dr. Jim Cleary. Jim is an Australian-trained medical oncologist and palliative care physician. Jim moved to the University of Wisconsin Colon Cancer Center 20 years ago, where he started a palliative care program. He now directs the Pain and Policy Studies Group, home of the WHO Collaborating Center for Pain, Policy and Palliative Care. He's active in international palliative care and opioid availability, especially through EPSD's International Pain Policy Fellowship. Since 2006, the IPPF has fellows in Vietnam, Nepal, India, Sri Lanka, Bangladesh, Armenia, Georgia, Serbia, Kyrgyzstan, Albania, Ukraine, Guatemala, Colombia, Panama, Argentina, Jamaica, Nigeria, Sierra Leone, Uganda, Kenya, and most recently, Ghana, Zambia, and Rwanda. Sudan and Ethiopia. Thank you.
Suwanda, that's a new country. But we do have a wide global impact.
Jim, you're not on the...
Yeah, that's okay. I'm not unaware of that. Thank you very much.
Sorry?
Thank you. Yes, Madam President. It really is a wonderful opportunity to be here, and thank the Lithuanian government for hosting us. I'm here as a representative of the International Association of Hospice and Palliative Care. But let me start with the story.
Here in the rural outskirts of Calcutta, India, top-notch medical care is hard to come by. But Dr. Abhijit Dam makes do. The day we met him, he had transformed this school courtyard into a makeshift clinic and virtual pharmacy, dispensing drugs for a variety of ailments. But when he heard reports of a woman dying of breast cancer in a neighboring village, Dr. Dam knew he was in for a challenge. The woman, named Fatima, had a massive breast tumor, clearly infected and clearly painful.
She has severe pain, she can't sleep at night.
Fatima's family says she screams in agony day and night. But because of strict narcotics laws, morphine, the gold standard in pain treatment, is nearly impossible to get in most of India. So Dr. Dam is forced to improvise with readily available analgesics.
This is really difficult to watch, and it's particularly difficult considering that, you know, with a 2 rupee medication, she would not be screaming.
So my plan today is to try and take you through some of the context as to how we've got here. And I'll be tweeting throughout this talk if you want references. They'll be available through both these hashtags, CND 2014 and HPM Global. But if we go back historically, and it'll probably, morphine has been around for some time and really became very useful clinically when the hypodermic syringe was invented in 1857 and particularly was used during the Civil War in the United States. But the first hospices we know were started in France in the 1840s. And I look, and hospice has been with us for many years. 1899, Calvary Hospice was started in New York. This is not a new phenomenon. And if we even look at the different opioids, oxycodone was developed in 1916. This has been by the Germans working on developing new medications. And just to bring in this cross-flow and the issues of addiction, and we think that this persecution of physicians who write opioids is new. Some 25,000 MDs were arraigned on narcotic charges in the US up until 1938, with many of them actually spending time in jail. During World War II, there was actually very little addiction as the traffic flow stopped from the Golden Triangle in Asia. We can look at some of the other medications that were developed, pethidine, another medication from Germany. It's interesting how much the Germans were involved in the development of these. Methadone developed as Dilorphin from the German, meaning end pain. But we can say, again, these medications. 1960, fentanyl developed. And I raise this as a pertinent issue because fentanyl is the last or the most commonly used medication in palliative care, but we're still using a 50-year-old medication. 60 when fentanyl was reduced, and this document you're all aware of, and let me remind you, and this is an and, the framework prevent abuse and diversion and ensure the availability of drugs for medical purposes. The WHO would ask us to use the term medicines and not drugs to define this. This was not an either or, this was the rationale. The medical use of narcotic drugs continues to be indispensable for the relief of pain and suffering. Adequate provision must be made to ensure the availability of narcotic drugs for such purposes. If we look at Dame Cecily Saunders from the UK, died recently, but she documented that the regular use of morphine at hospices in the United Kingdom resulted in much better improvement in quality of life. Balfour Mount established the term palliative care in Canada, in Montreal, and this was really bringing the hospice care into the medical systems in Canada at the time. This is important because he did a study in the 70s which actually compared oral morphine with Brompton cocktail. And what was Brompton cocktail? A medication that had been invented in 1893. So in my medical career, we were using a standard of practice that was developed in 1893. We hadn't come very far. And I raised this in 1977. The WHO Essential Medicines List was established. And what is an essential medicine? And as you read through this list, think, do opioids fit into this? To be available within the context of a functioning health system at all times, in adequate amounts, in appropriate dosage forms, assured quality and adequate information, and at a price the individual and community can afford. Morphine and codeine have been on that essential medicines list since 1977. You will see tracking along here is we've actually plotted opioid consumption on these graphs, and this is morphine equivalents. It does include methadone in this metric, and the countries I've highlighted here are the United States, Australia and Germany. Most of the other countries in the world are hidden behind this big yellow bubble, which is India and soon to include China. I put this picture of my parents here because, again, within my own medical career, my mother, who was a hospice nurse, gave the first dose of oral morphine in Adelaide, Australia. This is a relatively new phenomenon that we're talking about. But this is a very old drug, but up till that time they've been using Brompton cocktail in the hospice there. In 1986, the WHO released cancer pain relief with the three-step ladder using non-opioids, opioids for mild to moderate pain, and then opioids for moderate to severe pain as part of the process. And it was around this time that the Wisconsin Cancer Pain Initiative started in Wisconsin, and this was done as an effort, should we use heroin for pain relief? Those strange people in the UK are using heroin. Should the United States introduce heroin? And they decided, as you can well understand, heroin I have not prescribed in the 20 years I've been in the United States. But they actually encouraged the use of morphine and showed in early studies funded by the National Institute of Drug Abuse that there was increase in morphine consumption related to palliative care, but no increase in crime. And this came at a time, Charlie Cleland in Madison did a study that showed that at least 42% of cancer patients in the United States treated at the best cancer centres were being undertreated for their pain. PPSG, as we know it today, was established in 1996. And if you look at the United States and also Australia, the gold bar, we see this bump in opioid consumption. This was the release of MS-Contin at the time, and we start seeing this go up. We have a sustained release morphine product, and the consumption went up. Germany very slow in the uptake. We have in 1996 a second version of cancer pain relief, particularly associated with cancer, and a steady climb of opioid consumption. In 2000, Achieving Balance in National Opioid Control Policy was prepared by a working group of the WHO, and this took place in our collaborating centre in Madison. The question mark there, why are we starting to see a sudden bump? Oxycodone was released into the sustained release oxycodone was released in the United States, again by Purdue Pharma. This concept of balance, as we know it, is very important. National policy should ensure a drug control system that prevents diversion and ensures adequate availability. And I love the statement, drug control measures should not interfere with medical access to opioids. I do not feel, as a practitioner in the United States, that I practice in that environment where the drug control system does not interfere, and that's even working in a cancer centre. In 2012, we now have guidelines on pharmacological treatment of persisting pain with children, and you can see what's happened in the United States. The other small blip up, small blue dot is Canada, Australia in gold, Germany in green. We have many other green countries there, but most of the world's population almost no opioid consumption. And interestingly, this guideline moves to a two-step ladder. They've removed codeine because of issues of metabolism in children. And if we look at this overall map, you can see the major consumption here. But this is the disparity. We can see that the majority of the world's morphine is consumed by a very small percentage of the population. 16% consume 90% of the world's opioids. You can look at this in different ways. Excuse me. This is the INCB data, which uses statistical defined daily doses. We can see that per million people per day. We can see that the North America, colossal numbers, Oceania with the influence of Australia, Korea, Japan, and Europe. But then we see that countries who are using less than 200 statistical defined daily doses, the regional groups, and in fact, most of the regions of the world consume very little morphine or opioids. This is another common way that you may have seen this graph, and this is available from our website, the link of which I've just tweeted to you, hopefully, if the system is working. And these are other ways of showing it. This is a graphical map showing the size of the countries based on the consumption of morphine in a metric that looks at cancer and HIV deaths. And we can, the almost only identifiable countries, the United States or nations, regions, the United States, Europe and Australia, although they are so bloated in many cases, they're hard to recognise. This is another way of looking at it, a log graph on the y-axis, and I've highlighted some countries there to show that many of them are consuming less than 2 milligrams of morphine per person per day. In fact, on this log scale, many countries of the world are consuming less than 0.5 milligrams per person per day. Very, very low consumption, and we can see Australia's consuming 60 milligrams of morphine per person per day. Canada up in the region of something like 75 milligrams per person per day. This shows the equivalent data with total opioid consumption, morphine equivalents, including methadone. Methadone is used as a pain relief medicine in some countries, but in many other countries is only used for the treatment for harm reduction. We really became involved, or increasingly involved, when we compared Western Europe with Eastern Europe, and we actually showed in this case, in a study done by Nathan Cherney, that opioids were available in Western Europe. So if there's a coloured box there, you can see that the medication is available. If there's not a coloured box there, it's not available. We can see Western Europe, they are. The colours relate to cost, which is not so important today. But if we go to Eastern Europe, huge number of countries that don't have access to medications, including immediate release morphine and sustained release morphine, such the situation in the Ukraine up until recently only had injectable morphine available. And we visited the Ukraine, and this is a former KGB colonel who slept with a gun under his pillow so that he could end his life when his prostate cancer pain became too great. In the interest of time, I won't show you the video of him. WHO has had these essential medicines, particularly codeine and morphine, as I've said, since 1977. The International Association of Hospice and Palliative Care has actually been working to improve this list of medications. If we actually look, and they've established a very strong list of medicines, diclofenac, a non-steroidal, gabapentin for neuropathic pain. They also have medications which can be used for dyspnea, shortness of breath. But these are the opioids the IAHEPC is recommending: codeine, fentanyl, methadone, morphine, oxycodone, and tramadol. They have a yellow box warning, which is probably a little hard to read in this graphic, but they're actually saying that no country should approve modified release morphine, fentanyl, or oxycodone products until you've guaranteed the use of immediate release morphine throughout the whole country. So the palliative care list currently reads like this, and this year the WHO has included a separate palliative care list for essential medications. The only opioids currently on it, codeine and morphine. We need to be working hard to get these expanded so that we can get more opioids on the essential medicines list and ensure that they're absolutely available. Many countries, and I'll be talking more about this tomorrow in a session hosted by the Australian government, where we actually can show the availability of these medications. Yes, they're on formulary. But many countries of the world, and this is the recent studies from South America, the Caribbean, Africa, Middle East and Asia, have significant barriers restricting the use of opioids, controlled substances, for palliative care cancer patients. So if you're in pink or red there, you really have a significant number of barriers to providing the opioids. And laws are not the only reason. This is surveys of physicians, regulators, insufficient training, laws restricting, cost can be an issue, difficulties in distribution of the supply chain is a significant issue. But if we come forward, we see that there are three things we need